from Spain, from Madrid, right?
Yes, yes.
Yeah.
Nice to be here. Thank you very much.
Yeah. So, for those of you who don't know, which I'm sure many in Europe already know you, but for those in the U.S. who don't know, Dr. Galvan is one of the leading hair loss doctors in Europe. You've done a lot of studies in regards to low dose oral minoxidil. You and Dr. Oscar Munoz are two of the top doctors, and I believe that you're actually affiliated with Dr. Munoz, right? You guys work closely
Yes.
together.
Yes, absolutely. We work together and we have a huge team of 20 dermatologists focused on hair disorders. So we are very lucky. We perform a lot of studies. And well, it's a pleasure for me to be here with you, Melvin. Thank you very much.
Yeah, so let's jump right into it. There's a lot of people that are scared of oral minoxidil. I personally started taking it back in August. Currently taking about 2.5 to 5 milligrams daily, and it's been great. I've no side effects, no edema, no arrhythmia from my heart, no heart palpitations, nothing like that. I do feel like my body hair grows faster, but that's about it. But there's a lot of concerns of heart issues. People are scared that there might they might be at increased risk of like a heart attack or something like that, and so they're very scared. And I know you did a large study in 2021 looking at cases, and I was very shocked and surprised to see that the serious adverse effects was only like, I believe, 1%, 1.3% or something like that. um, so maybe you could talk a little bit more about that.
Yes, in fact, this multi-center study that has been the largest study, largest published study to date, included more than 1,400 patients treated with low-dose oral minoxidil. And interestingly, we didn't observe any serious side effects. Only 1.7% of the patients had to stop the treatment due to side effects. It means that more than 98% of the patients tolerated well the treatment, and in the cases that the patients had to stop the treatment due to side effects, these side effects were mild or moderate, mainly hypertrichosis, fluid retention, lightheadedness, or tachycardia. So, this study strongly supports the good safety profile of low dose oral minoxidil for different types of alopecia, not only androgenetic alopecia, but also telogen effluvium, alopecia areata, or cicatricial alopecias. At least in Spain, one of the main problems of oral minoxidil is that we have to compound it. So when we deal with a patient with a systemic side effects, the most frequent cause in our environment is a compounding mistake. So it's really important that if the medication is compounded properly, the risk of systemic side effects is very low, and the risk of serious side effects is really, really low.
Mm. You bring up something interesting. I know a lot of people were asking me, um, is it difficult to get oral minoxidil in Europe? Is there a shortage? I heard that there's some sort of shortage or something like that.
Well, Pfizer has marketed Loniten 10 milligrams tablets in Spain, but it's out of stock. So we need to compound it for the dose of
Mm.
men, 5 milligrams or 2.5, and especially for the dose of female patients, 1 milligram daily. We have to compound, and we have to talk to the pharmacy to properly compound this medication, because some compounding mistakes have appeared in the last years, especially 5 or 6 years ago, when the pharmacist started to compound this medication, and we observed more side effects a few years ago compared to currently, because nowadays the compounding is process is better compared to a few years ago. Yes.
Yeah, so that's interesting. So in your large study of like 1,400 patients, you feel that some of the side effects may have been a result of poor compounding or incorrect compounding by the pharmacy.
Yes, absolutely. I'm almost sure that in our environment, the most frequent cause of systemic side effects is a compounding mistake. And when we properly compound the medication, when we give this low dose oral minoxidil, only 1 milligram or 2 milligram for female patients daily, or even 5 milligram daily for men, the safety profile is really excellent. We have not seen any heart problem. In fact, we have talked to the cardiologist, and this medication
Mhm.
can be also prescribed, for example, for patients with high blood pressure, which are taking other medications. And this low dose oral minoxidil can even help these patients to control their blood pressure. So it's not only for the good for the hair, but also probably for their blood pressure.
Yeah, yeah. That's how it started off, right? It started off as a blood pressure medication, and then they found secondary effects and the topical. Someone asked in the thread in a hair restoration network. Someone asked, "Are there any studies comparing the topical minoxidil versus the oral minoxidil to see how much more effective the oral version is than the topical?" Because of course people are always a bit scared and they would prefer to take the topical because it may be safer. What's your opinion on that?
Well, there are very few studies comparing oral minoxidil and topical minoxidil. The feeling that all the doctors have is that oral minoxidil is more effective compared to topical minoxidil. And the most important advantage is the good compliance by the patients, because it's rare for a patient to apply twice daily topical minoxidil while the intake of one single tablet per day of oral minoxidil has a really high compliance. So from our perspective, the effectiveness of oral minoxidil is dose dependent, so we can even increase more the dose of oral minoxidil to increase the effectiveness. And I think that it's probably the most useful emerging therapy in the last 5 or 6 years in the field of hair disorders.
Wow. So I mean, it's been around forever. Why do you think people are just now starting to take it? I know that Dr. Sinclair in
Mhm.
Australia was one of the first doctors to really study it orally. But like what do you think changed? Because in the US it's been so hard to get a dermatologist to prescribe it because of the topical version. They're always going to say, well, just take the topical. But in my experience, in my personal experience, having used the topical for almost a decade and now just switching to the oral 6 7 months ago, the change is dramatic. The hair thickness is it's improved. I mean, efficacy to me seems at least 40% more effective
Mhm.
in the oral version.
Yes, completely agree. I think that Dr. Rod Sinclair was the pioneer regarding the use of low dose oral minoxidil for hair loss. It already existed, but people didn't know about it. So I think that in the last 6 or 7 years, we have been using oral minoxidil in different parts of the world. Listening to the lectures of Dr. Rod Sinclair, we started the use of oral minoxidil in Spain in 2016. And since that point, we have been using it and giving lectures to other doctors in South America, in other countries. And I think that the use of oral minoxidil has increased dramatically in the last 3 or 4 years. Different studies have been published supporting the effectiveness and safety of this medication, especially several studies in the Journal of the American Academy of Dermatology. These studies have led other doctors to increase the use of oral minoxidil for androgenetic alopecia and other types of alopecia. And I think that currently this is one of the first line treatments for male and female androgenetic alopecia. And we have also seen an increase of its use in other types of alopecia, like chronic telogen effluvium, frontal fibrosing alopecia, even alopecia areata and other cicatricial alopecias.
Yeah. I I got a question here in the forum. Somebody had said that the study was an analysis of patients, and they're wondering if there's going to be any randomized controlled studies looking at both the efficacy and the safety profile of oral minoxidil. If you guys have any plans on doing that in the future.
Well, we will collaborate with a multi-center clinical trial regarding the use of oral minoxidil that will accurately measure the effectiveness and safety of oral minoxidil compared to topical minoxidil and placebo. Yes, yes. And there are some other ongoing clinical trials regarding sublingual minoxidil. So
Mm.
we will be able to compare the different safety and effectiveness profile between oral minoxidil, sublingual minoxidil, topical minoxidil, and placebo.
Ah, got it. Let me ask you this. A lot of people are saying, and they're speculating that topical anti-androgens are sort of just like hype and marketing, and that there's not really a use for them. Personally, I use a topical dutasteride, which there's some speculation that the molecular weight is large. The molecular weight is larger, right? I think it's like 537 Dalton, which means it is at that very threshold where it may not penetrate the scalp. So some people think that it's not effective because of its large molecular weight. Other people think that it's still small enough to penetrate, but won't give you the same side effects. We know that topical finasteride, there's a lot of studies uh, showing that it is effective, but I'd like to get your thoughts on that. What are your thoughts on topical finasteride, topical
Mhm.
dutasteride, and these other topical anti-androgens that are in the pipeline?
Well, there are a lot of new topical anti-androgens. The classical one, topical finasteride, it has demonstrated to be safe and effective. Not as effective as oral finasteride, but it can achieve more or less an 80% of effectiveness of oral finasteride. The main advantage, in my view, is that we avoid the nocebo effect and the worrisome of some patients regarding the sexual side effects of the oral medication. Regarding topical dutasteride, the weight of the molecule is high, so there are some doubts regarding the absorption. As dutasteride is much more potent than finasteride, it makes sense that even with a lower penetration, it can produce some degree of effectiveness. Of course, not as effective as oral dutasteride, but perhaps it's another interesting option if we give with the proper vehicle. The other new topical anti-androgens like topical clascoterone, it has been approved for acne vulgaris in the US, and there are some studies evaluating the effectiveness for androgenetic alopecia. These studies have shown that the result is not as good as topical minoxidil, but there are other topical anti-androgens like some molecules of the Kintor company like
Mm.
pirilutamide, or even some new technologies like Cosme RNA that targets the androgen receptor synthesis. So I think that we are like living a new generation in research regarding the targeting of androgen receptor. And there is the new monoclonal antibody which is HMI 115 that inhibits the prolactin receptor. So I think that this we are going to see a change of the paradigm of this anti-androgen mechanism in the treatment of androgenetic alopecia. But answering your question, I think that topical finasteride and topical dutasteride might work, and I'm sure that they work in our patients, but the degree of effectiveness is lower compared to the oral medication.
Yeah, absolutely. I think without a doubt, um, oral medications are always going to be more effective, even with, I mean, topical minoxidil and oral minoxidil. Topical minoxidil still works, but it's not going to be as effective as the oral version. The main thing I think that for anyone out there is, for me, I took the oral finasteride and I got the negative side effects. Um, so for me, it was no longer an option. So it's always good to have something out there. Something is better than nothing, I think, in my opinion. At least you're doing something. You bring up something very, very interesting that a lot of people are talking about is the Cosma RNA and the pyrrolitamide. I asked Dr. Munoz about pyrrolitamide last year, I think in August, and these were his concerns. His concerns were that number one, he doubts that it will be more effective than oral dutasteride. Number two, he thinks that it will be a topical version, which will then not be as effective as dutasteride. But he also, was a little bit weary about shutting off androgen receptors because he said that if you shut down androgen receptors, the likelihood of side effects are a lot higher, more so than oral dutasteride, which I found very interesting because people are looking at pyrrolitamide as something that will not have the same negative side effects because you're not inhibiting DHT. So in their minds, well, I'm not inhibiting DHT, so I should be fine. But you're shutting down the androgen receptor. So if you could just kind of explain to the public the difference between, inhibiting the 5-alpha reductase enzyme, which blocks DHT, as opposed to stopping or blocking androgen receptors themselves. What's the difference? Why is blocking androgen receptors going to be more, possibly cause more side effects?
Well, yes, I completely agree with my good colleague Oscar. This lesson we have learned it from the management of female pattern hair loss. We have two types of anti-androgens for them. We can use 5-alpha reductase inhibitors, finasteride or dutasteride. They block the transformation of testosterone to DHT. And we can give other kind of medications for female pattern hair loss, like oral spironolactone or oral vicalutamide. They are androgen receptor inhibitors, and they have a different safety profile and different effectiveness because they can not only increase the hair density, but they can increase, they can improve the seborrhea and other hyperandrogenism signs, and they can have other side effects like dryness and so on. So I agree that if we target directly the androgen receptor, we can expect other types of side effects compared to 5-alpha reductase inhibitors. Probably if we apply them topically, the risk of these side effects will be lower, but we have to see them in the clinical trials that are ongoing. So I agree with my colleague Oscar. We have to wait. They are going to be probably a very innovative treatment, but we have to see the different safety profile compared to 5-alpha reductase inhibitors.
Yeah. Have you seen the phase 3 clinical trials from Kintor?
Not yet.
Not yet? Okay. Yeah, because I thought if you're going to treat hair loss, I think that targeting the androgen receptors and blocking them makes the most sense on paper. But can you do that locally? That's the question, right? Because the whole reason why, topical, 5-alpha reductase inhibitors like finasteride and dutasteride are created is really to supposedly locally stop the DHT or block DHT on your scalp. What is the mechanism? You mentioned Cosma RNA, which I'm not too familiar with, but a lot of people have been talking about it on the Hair Restoration Network and on other forums and stuff like that. What is it? How does it work? And what are your thoughts on it?
Well, it's a new way of doing this anti-androgenic effect because they are little molecules called RNA that inhibits the protein synthesis of the androgen receptor. So this is kind of like inhibiting the creation, the development of the androgen receptor. So it's a more persistent effect. It's going to be a topical medication as well. There are some recently published research showing its effect applied once daily and even 3 times a week. And probably it's going to be a new way of doing this anti-androgenic effect. I think that the effectiveness is going to be probably higher compared to other anti-androgenic topical treatments, but we have to see the real effect in clinical practice, and of course the safety profile, which I expect that it's going to be a good safety profile. We have to wait until more studies are done.
Mm. So it blocks the protein synthesis of the androgen receptor. Uh, but how does that? So is it sort of like pyrrolitamide where it shuts off the androgen receptor so the DHT can actually bind to it? Is it the same sort of mechanism of action?
It's like the next step because it inhibits the formation, the creation of the androgen receptor, because it inhibits the protein synthesis due to this RNA. It's like
Mm.
something quite a bit different of pyrrolutamide, but the final mechanism of action would be targeting the androgen receptor. So we can imagine two groups of medications: 5-alpha reductase inhibitors and blockers of the androgen receptor. This cosmer RNA would be inside this group, these blockers of androgen receptor.
Mm. Yeah, my only thing is like what Dr. Munoz said is, are you going to be, because there's so many androgen receptors in our body. I mean, there's in our shoulders, in our neck. I mean, is it gonna is it gonna stop the creation of these other androgen receptors that could then, lead to all these other side effects and issues, especially in men, low
Yeah.
libido and all that stuff.
Yes, well, this is one of the reasons because this treatment is going to be developed topically. But of course, we will have to wait until the results of these clinical trials.
What do you think, in your opinion, is the most interesting and I would say what do you think is going to be the most effective treatment that's coming out in your opinion?
Well, we are talking about androgenetic alopecia for male and female patients. For male patients, I think that the most potent medication nowadays is the combination of oral dutasteride, oral minoxidil, mesotherapy with dutasteride, and the topical application of different products like minoxidil and anti-androgens. And the role of PRP or other regenerative medications or procedures nowadays, or light therapies, in my opinion, are less effective. And for female pattern hair loss, the strategy would be very similar: oral minoxidil, oral anti-androgenic drugs, mesotherapy. We can combine dutasteride, bicalutamide, and even PRP, and topical products. This is what we are doing nowadays. For the future, I think that we will see a revolution regarding regenerative medicine, but not in the short term, but in the long term. The clinical trials that have been performed in humans regarding the hair cloning are still very preliminary, and the results are not good enough to be optimistic in the short term. But I'm sure that in the long term, probably in 10 years, we will see these different types of regenerative medicine or procedures that will help us to treat our patients. I'm talking about the different devices like the mesenchymal stem cells or the regenerative eyes. Well, I think that they have to improve the technique, but in the future, I think that they will be a milestone in the treatment of androgenetic alopecia.
Have you heard of hair clone with Dr. Farjo and in the UK?
Yes.
Um, he's doing something very similar, regenerative. It's not necessarily hair cloning, like he's not
Mhm.
cloning the actual hair follicle itself, but he's multiplying the dermal papilla cells
Mhm.
that are resistant to DHT,
Mhm.
and he's placing them in the scalp. So it's an interesting concept, but yeah, I think there's still a few years before that's going to be an effective treatment.
Mhm.
Um, so out of all the pipeline drugs, we got pyrrolitamide, we have clascoterone or Breezula, we have this Cosma RNA. Um, Am I missing one? There's the other one you mentioned. It's
HMI
HMI
115.
100. Which out of all those do you think, if you're a betting man, if you had to bet money, which one are you betting on? Let's say it's a 4-horse race. Which one's gonna win in your opinion?
Well, probably it's a very difficult question. Probably the monoclonal antibody, the HMI 115, is very preliminary. But thinking about the mechanism of action, probably the cosmic RNA would be the first one, in my opinion, followed very closely by pyrrolutamide, and then I would position HMI 115 and clascoterone in the third position. Yes.
Wow. So the Cosmo RNA lives up to the hype, in your opinion. It may live up to the hype. That's very interesting. I, it's like these things just pop out of nowhere. I didn't even know about it just a month ago. Just
Mhm.
recently, I started hearing of Cosmo RNA. So if it does get released, when do you think it would get released?
Eh, Probably, I think that, well, taking into account the different phases of the study, probably Cosme RNA can be released firstly, I think, because clascoterone is very, the trials of alopecia are really slow. There have no been advances in the last months or years, and I think that Cosme RNA probably are going to be the first one, probably with also with perlutamide in second position.
Mm. Yeah, they're I believe already in their phase 3. My only concern is and uh I guess without being politically correct, it's a Chinese company, and I don't know how much we can actually trust their data.
Mhm.
I don't know. That's my feeling. So I don't know. Is it gonna get approved here in the U.S. at the same level? Looking at the same data, that's my only concern. But
Mhm.
the company that's making Cosmo RNA, where are they from?
I think that they are from Korea or from Japan.
Oh,
Yeah,
yeah, yeah, yeah.
yeah, yeah.
Korea, yeah, yeah.
Korea.
That's
Yeah,
from
I think it's
Korea.
Korea because they have different researchers, but I think that the main doctor there, Yul, is from Korea. Yeah.
Mhm. Yeah, I think that Cosmo RNA is probably gonna, like, I think you're right.
Mhm.
They're gonna go up first. What are your thoughts on Dr. Suji and the Shishido? Do you
Mm.
remember that the
Yes.
Shishido? It was supposedly gonna cure hair loss in 2020. I mean, it's 2023 now, and nothing. Do you think that hype just fizzled? It's done with?
Yes, I was remembering the name of Jun Park. He's from Cosme RNA, I think, from Korea. Yes.
Yep.
Well, regarding the study, Shiseido and so on, I think that this is the eternal promise in the future. But I think that more research, more basic research is needed before we can think about this type of procedure in humans in real clinical practice. One thing are the data in mice, in murine models, and other thing, very different thing, is to do it in humans and to do it in clinical practice. So I think that for these kind of procedures, real hair cloning, and so on, I think that we will have to wait at least 8 to 10 years, because I have been hearing about stem cell therapy. I think for the last 20 years, and it's
Oh
always
yeah.
like 10 years. In 10 years, we will have this treatment available.
Yes.
But I think that we have not almost advanced anything in the last 5 years, from my perspective. So I think that we will have to wait a few years is the yet. Sorry.
Yeah. I sent you so I had a podcast with Dr. Barkuthi of Jordan on Saturday, and I sent you the video on verteporfin. So just a quick synopsis, because I don't know if you're too familiar with it, but just a quick synopsis. Verteporfin was a drug that was studied by scientists in Stanford, and they found that when they created a wound um, on mice, and they injected it with verteporfin, the hair follicle grew back with all of the dermal appendages, and it was a terminal hair. So Dr. Barghouti took it upon himself to start studying this in conjunction with FUE. So he extracted an FUE graft and immediately injected the site with verteporfin. I believe he's at 10 months now of his trial. It's only one patient, but so far he did a biopsy, and the pathologist found that the test site had double the amount of hair compared to his controlled site. Um, this is, in my opinion, pretty groundbreaking. I know a lot of people in the hair restoration network and abroad are very excited on this. And I've sort of taken it upon myself to reach out to people like you who are heavily connected in the research field, heavily connected with clinical hospitals and universities that could conduct a study. So I just I'm bringing it out to you to see if possibly you could look into it and maybe, start more studies, because I think it's something that definitely needs to be studied a little bit more. Is there something to it? I think at worst, it could significantly improve scarring in hair transplant procedures. Um, at best, it may regenerate some hair. I mean, just by
Mhm.
looking at the pictures visually, and I'll share them with you after the call, but just by looking at the pictures visually, there is a visual significant difference from the test site to the um, controlled site. Whether that's the prevention of these fibrotic pathways of scarring, I don't know. I'm speculating that there has been some hair regeneration based on what the
Mm.
pathologist said of the biopsy, but yeah, I'm bringing it out to you and throwing out the line to you and Dr. Munoz, because you guys are at the forefront of conducting research for hair loss and hair transplants. So maybe you can look into it.
Yes, of course, Melvin. Thank you very much for this new study. I think that we have a great deal of new developments in the treatment of androgenetic alopecia. Not only this one that we will definitely look and jump into it, but also botulinum toxin, PDO threads. There are different new developments that we have to test. Of course, from the scientific point of view, we have to design studies and check the safety, the effectiveness. But of course, we are living very great times in the field of hair research, and we have a lot of treatments that are more effective compared to 10 years ago. So I think that, of course, we will definitely look at it.
Great. It looks like we have a couple of questions here. Let's go to some questions.
See, okay, so Andy Armstrong is asking, does the efficacy of oral minoxidil vary for patients with hypertension versus patients without?
No, the effectiveness is the same. It can vary the safety if the patient is taking a lot of antihypertensive drugs, but we have seen in a study that we're going to publish that the majority of antihypertensive drugs are safe when using low dose oral minoxidil with them. So there are no interactions.
Mhm. You mentioned earlier about the topical anti-androgens like finasteride and dutasteride possibly being effective with the right vehicle. Um, what do you think the right vehicle would be? Would it be a liposomal vehicle? Um, in your opinion, what would be the right vehicle for a?
Well, I'm not expert in the chemistry of these type of vehicles, but the best vehicle would be the vehicle that can facilitate the penetration of these high weight molecules into the skin, probably liposomes or other chemical vehicle that can obtain a deep penetration of these high weight molecules. Yes.
Mm, got it. Do we got any other questions, Jerry?
Yeah, next question is from DK. question is, any thoughts on microdosing finasteride, like 0.25 milligrams a day?
Mm,
Is it worth a try?
good question.
Yes, I think that the effectiveness is not as high as finasteride 1 milligram daily, but it has been demonstrated that this very low dose oral finasteride can be effective in some patients. And there was a study in the last World Congress for Hair Research in Melbourne a few months ago that I traveled there, that they compared the maintenance treatment with finasteride daily, 1 milligram daily, or finasteride every other month. So 1 month active treatment, 1 month without treatment. And they showed that the maintenance therapy was they had almost the same effectiveness. For some patients, this very low dose or even this intermittent treatment can be also effective. But of course, and for
Mm,
sure, it's not as effective as the higher dose.
yeah, I mean, in your opinion, for someone who suffers from side effects, because what Dr. Munoz said is that there's a threshold for every treatment, every medication. Um, what that threshold is different for everybody, right? Some patients get no side effects on 1 milligram of finasteride, and once you introduce zero point 0.5 milligrams of dutasteride, then they start getting side effects. Other patients can do, you know, zero point 0.5 milligrams daily of dutasteride and not get any side effects. Other patients have to do zero point 0.5 milligrams of finasteride. So the range is quite high and different. But for those who are suffering from side effects from, let's say, 1 milligram of finasteride, what would be the protocol that you would suggest to them?
Well, it's a very interesting question. In fact, I have received many patients with this problem, and I have switched to low dose oral dutasteride. In my opinion, I think that low dose oral dutasteride is a very interesting treatment for early decrease of androgenetic alopecia or as a maintenance therapy. Why? Because dutasteride has a longer half-life compared to finasteride, and we can give only low dose oral dutasteride, which is only 2 or 3 capsules of 0.5 milligram weekly. For example, Monday, Tuesday, Wednesday. And in my experience, some patients with side effects to 1 milligram daily of finasteride, they have tolerated fine 2 capsules of 0.5 milligram dutasteride twice a week. So I think it's a very interesting option for patients that are afraid of sexual side effects or for patients that have developed side effects to finasteride.
Ah, that's that's interesting. People are gonna say, well, I thought dutasteride was more powerful. How is it that switching from finasteride 1 milligram to dutasteride, how is that gonna stop their side effects? But you're saying by doing it low dose and intermittently only 3 times per week as opposed to daily use, um, you've solved that, or the patients no longer had the side effects.
Yes, and it was published a study in the Journal of the American Academy of Dermatology comparing different doses of oral finasteride and oral dutasteride. And they showed that 2 capsules of 0.5 milligram weekly of oral dutasteride was as effective as finasteride 1 milligram daily. When we have been using this protocol in our daily practice, we in fact published our results in our cohort of men treated with oral dutasteride. We didn't observe any patient that had to stop the treatment due to side effects in the low dose oral dutasteride cohort of patients. We are talking
Wow.
about 2 or 3 capsules of 0.5 milligram per week, given in consecutive days, Monday, Tuesday, or Monday, Tuesday, Wednesday. So I think it's quite interesting because we have all seen a lot of patients with side effects to finasteride when administered daily. But with this protocol of low dose oral dutasteride, the safety profile in our hands is really, really good.
Mm. Now, what do you think of if someone were to say, do the same thing with finasteride? Let's say 1 milligrams Monday, Wednesday, Friday. Is it still effective? Is it still, in your opinion, a good protocol?
Well, I think that it doesn't make the same sense compared to dutasteride, because the half-life of dutasteride is 5 weeks and the half-life of finasteride is 5 hours. So I
Mhm.
think that probably it works, but not it doesn't work as good as with daily administration of finasteride. So I think that this intermittent administration works better with dutasteride due to the longer half-life.
Got it. Yeah, I've
And,
always
and if I can comment, if I can elaborate on this, this is one of the main reasons, because we are using mesotherapy with dutasteride instead of finasteride due to the longer half-life. And we have published, my colleague Dr. David Saceda have published a study about the protocol with sessions of mesotherapy with dutasteride every 3 months, and we have demonstrated a good degree of effectiveness and, of course, a very good safety profile. And in our hands, it's not as effective as oral dutasteride, but it can be another interesting options for patients that don't want to take systemic medications.
perfect. That's a perfect segue, Jerry. If we can pull up his result here, we have a patient here with extensive hair loss. This is Norwood 6, bordering Norwood 7 pattern with a lot of diffusion here. And if you can just break down your protocol for this patient, Dr. Vaño, what did you use?
Yes, in this patient, he came to our consultation asking for a hair transplant, and we recommended to start with medical therapy in order to stabilize the alopecia and see if we could obtain any degree of improvement. And we started with oral dutasteride, 0.5 milligram daily, oral minoxidil, 5 milligram daily, and 3 sessions of mesotherapy with dutasteride separated by 3 months. And after 1 year of treatment, we observed this dramatic improvement. The patient didn't have to undergo a hair transplantation. He was very happy, and he's under maintenance treatment with we have decreased the dose. He's taking 4 pills of dutasteride and minoxidil per week, and we perform injections of dutasteride every 6 months. And he's really happy. And this kind of response is not rare in clinical practice, especially if the
Wow.
patient has a lot of thinning hair on their scalp. So I think that we can start with medical treatment, and after 1 year, consider the hair transplantation.
This is an incredible. So this is not something that's unseen. This isn't like an outlier. Because I looked at this and I thought, well, maybe this guy's just what people call as a hyper responder, someone who responds extremely well to medication, which the vast majority may not respond that well. But in your experience, that's not true.
No, no, no. It's true that not all patients respond with this degree of improvement, but in our experience, we can obtain this degree of improvement in not less than 20% of the patients that present with a diffuse androgenetic alopecia pattern.
Wow, that's incredible. Wow. Let's go to the next case and look at this case because I thought this was an interesting one as well. This is another guy who I would categorize as a Norwood 5, probably, maybe Norwood 5V. And this looks like an amazing hair transplant. I mean, this
Mm.
looks like something from like Dr. Cuoto,
Yes,
uh,
yes,
FUE expert. But
yes.
this is only medication.
Well, yes, it's our main strategy in our patients is to when we deal with a naive patient, we prefer to start with medical treatment for 1 year in order to stabilize the alopecia and to see if we can improve the hair density before the hair transplantation. So, like the case before, in this patient, we started with oral minoxidil and dutasteride combined with mesotherapy with dutasteride. After 1 year, we observed an improvement in the hair density, and we can see that the crown became smaller and the frontal density improved. So then we advise to our patient to undergo a hair transplantation, a big FUE, a hair transplant, to try to improve the density not only in the frontal area but also in the mid scalp and in the crown. So we perform an almost 4,000 follicular units transplantation, and the result 1 year after the transplantation, of course maintaining the medical therapy, was really good. And I like this sequence because it shows the best way in the treatment of the patients with androgenetic alopecia from our perspective, which is first of all to treat with medical treatment and then to
Yes.
consider the hair transplantation in some patients.
That's what I've stressed so much, and I've always said the first line of defense is medication. And I think, and I've said this before on the forum many times, but getting a hair transplant without treating the root cause is sort of like putting a band-aid on a deep cut.
Mhm.
You have to treat the root cause, because otherwise you're just going to keep losing more hair, and trying to replace that hair loss with more hair transplants, you're going to run out of donor hair.
Mhm.
And then you won't have any options left. So it's always best to treat it with medication. I think he's responded well, and I didn't know that was a hair transplant, but that was fantastic. Did you do that? That was that your work, or was that one of
Yes,
your
yes, of
colleagues?
course, yes, of course. All the patients I post are done by my hands.
Wow, fantastic! I didn't know that you were that much of a hair transplant surgeon, but that's great work. I feel like there's so many excellent doctors in Spain. Uh,
Thank you very
Um,
much.
so many. I mean, there's De Freitas, there's
Mhm.
Quoto, obviously Dr. Lorenzo, who
Mhm.
was, the pioneer of hair transplants in Spain. There's Dr. Villa. I mean, the
Mhm.
list goes on and on and on. Why is that? I think I asked that to Dr. Munoz, and but why is there's just so many good, talented surgeons coming out of Spain? And Portugal also. There's Dr. Pinto and
Yes.
Dr. Ferreira, both excellent
All of
surgeons
them
as
are
well.
very good friends of ours. Well, I think that the field of hair research and the field of hair transplantation is very trendy nowadays, and probably since 2015 there are a lot of dermatologists and other doctors that are really interested in this field. So I think that we are in good at a good time regarding this field in our country.
Absolutely. Let's go to the next case that we don't have a lot of females usually talk to us, but there have been a few that have reached out to me that are interested in treating hair loss. And when you're dealing with female pattern hair loss, it's the psychologically it's a lot worse than men. Usually it can be really debilitating. So it's great to have some options. If we can walk through these cases here, how did you treat these patients?
Yes, on the top of the slide, this was a young lady with androgenetic alopecia, and we treated with low dose oral minoxidil, very low dose, 0.5 milligram daily or 1 milligram 3 times a week, with low dose oral bicalutamide, this androgen receptor inhibitor that we talked before, 50 milligrams 3 times a week, and we combined with injections of dutasteride. We are performing a study combining oral medications in female patients, oral anti-androgens, combining 5-alpha reductase inhibitors and androgen receptor inhibitors with a very good result, because the combination of both mechanisms of action are interesting from our perspective. At the bottom of the slide, we can see one of the very first patients with androgenetic alopecia that we treated with oral minoxidil 1 milligram daily in monotherapy, and we observed a really great result with this single treatment after 1 year of the medication. So I think that for female patients, oral minoxidil is really effective, and in some patients we can combine with anti-androgens, giving them orally or in mesotherapy or even topically, and we can even improve the result.
Wow. So and correct me if I'm wrong, but anytime a female comes to me and asks me like what the protocol, my go-to is always oral minoxidil, um, oral spironolactolone, um, or progesterone. Those are the main things that I usually suggest, because progesterone does have been shown to be a 5-alpha reductase inhibitor. it goes in line with female, hormones. And I always thought that was the safest and most effective. But you're bringing something completely different and very interesting to me. The dutasteride mesotherapy
Mhm.
injections is something that's very interesting. The use of 5-alpha reductase inhibitors isn't usually advised in women. Maybe you can tell us why, and why that is.
Well, I think that 5-alpha reductase inhibitors are not the most effective treatment in female patients, but we can combine them with oral minoxidil and with androgen receptor inhibitors like spironolactone or vicalutamide, and we can even improve the effectiveness. On the other
Mhm.
hand, regarding mesotherapy, we have been using PRP for a long time, but when we started the use of mesotherapy with dutasteride, we observed better results with dutasteride injections compared to PRP. And in some cases, we are even combining both. But of course, oral medication, so the combination, for example, of oral minoxidil and oral spironolactone is the best combination for female pattern hair loss in my experience.
Okay, so still the go-to for women is oral minoxidil, oral spirolactone, and possibly bicalutamide, which is sort of like pyrrolitamide, which is an androgen receptor inhibitor. Okay, perfect. Looks like we have a couple of questions. We can click off the presentation here. What's the next question we have?
What are your thoughts on sublingual minox?
Mm, Thoughts on sublingual minoxidil?
Yeah, sublingual minoxidil is another excellent idea of our colleague and good friend Dr. Rod Sinclair. It avoids the first liver step, so theoretically, with a lower dose, we can obtain the same effect, so we can optimize the safety profile. It's true that the safety profile of oral minoxidil is pretty good, so I'm not completely sure about the advantages of sublingual minoxidil. Probably one of the main advantages is that it can obtain the FDA approval before oral minoxidil, but we have to wait for it. So I think that both oral minoxidil and sublingual minoxidil are very good treatments, and at least in Spain, it's very difficult to compound sublingual medications, and it's quite easy to compound oral medications. So it makes the difference here in Spain.
So you guys don't have Lonitin in
We
Spain?
it's very difficult to obtain it in the pharmacies because it's out of stock nowadays. So we have to compound.
Mm, Got it. Let's go to the next question.
All right. Looks like you guys touched on this a little bit. It's a 1 milligram oral finasteride 3 times a week? Question mark.
Yes, if it's still effective.
Yes, I think we already answered this question. Perhaps it works, but it doesn't work as well as finasteride 1 milligram daily due to the short half-life of finasteride.
What would you say is someone taking just 0.5 milligrams weekly of dutasteride? Would
Well,
that be better than taking the finasteride?
In the study that I mentioned before, 0.5 milligram weekly of dutasteride was not as effective as finasteride 1 milligram daily, but perhaps it had between 30 and 40% of the effectiveness of finasteride 1 milligram daily. So I have some patients that they say, Sergio, I don't want to take any oral medication. And I try to convince them to say, just only take one pill of dutasteride weekly. And they feel the improvement. It's curious. It's not a very dramatic improvement, but they feel the improvement. So I think that even one pill of dutasteride weekly works.
Perfect. Yeah, and I think that for anyone on a budget, and that's a big concern for a lot of men, the topical formulations of dutasteride and finasteride can be quite expensive because, well, the one I'm taking is 2% dutasteride. So that's how many milligrams would that convert to? I believe 20 milligrams. Um,
Can you
two,
repeat, please, Melvin?
so I'm taking 2% dutasteride.
Yes.
I believe that's when you convert it to an oral medication, that's 20
Mhm.
milligrams.
Yes.
So
Yes,
it's
like
quite
minoxidil.
yeah. So it's quite expensive
Mhm.
to compound at the
Mhm.
pharmacy. So it's an expensive medication. It's over $100 a
Mhm.
month. But so I've always suggested to people that are on a budget that don't want to that they don't want to take so many pills, but also they don't have the same money to spend on these topical medications. I've always suggested, well, 0.5 milligrams of dutasteride once a week, just do
Mhm.
that because it's better than nothing. And it's very
Absolutely.
cost effective, very, very cost effective.
Completely agree.
We got another question here. Uh,
I thought that finasteride stays in the patient's system for 30 days.
Well, not really. The half-life of finasteride is 5 hours, so it remains in the blood and in the body 5 times the half-life. So it would remain 3, 4, 5 days at most, but not 30 days. Perhaps this number is due that when a female patient is taking finasteride, we should separate if they want to look for pregnancy, we should separate this 1 month, but it's for safety issues. It's to be sure
mhm.
that there's no molecule of finasteride on the body. But the real time that the finasteride remains in the body is 4 or 5 days.
Got it. Great information. We got another question here.
Let's see. Does finasteride work for a lifetime with 1 milligram?
Well, it can work, but there are some patients that the effectiveness decrease over time. And in these patients, we try to switch to dutasteride. So not all patients maintain the same effectiveness taking finasteride over time. So we have to monitor the effectiveness, yes.
I've suggested to patients, like I have one good friend named Armin who he's been on finasteride for he's 50 now, since 25 years. So he's been on it since he was 25. So he's been on it for 25 years, and he noticed some slight thinning in the crown, like it's slowly, not being as effective. I told him to take 1.5 milligrams of dutasteride per week. Do you think that that's a good protocol, or would you tell someone in that position to just completely switch to dutasteride?
Well, very good question, Melvin. A few years ago, I would have combined both treatments, but nowadays, I would directly switch one treatment to the other because the effect of dutasteride is higher compared to finasteride. It's true that if the patient is tolerating fine the treatment, and if we only want to try to increase the density in one area, perhaps you can combine. But if we see a non-responder to finasteride, we definitely would switch to dutasteride, not combine them.
Yeah, absolutely. Yeah, I think that's a good protocol. Well, let's see. Let's get the next question.
All right. Dr. Vano, can you discuss two cases of paradoxical non-scarring alopecia after mesotherapy with dutasteride?
Yes, it's a really infrequent situation, fortunately, but there are some cases of this kind of lichen planopilaris like alopecia after mesotherapy, not only with dutasteride, but with other different actives. And I think that the reason is to inject a high volume per point of injection, or probably the vehicle of dutasteride with ethanol. This is, I'm reading the other question, if we use dimethyl sulfoxide or ethanol, where our pharmacists try to combine little amounts of both. But I think that the good tip is to avoid a high volume per injection. We have been doing mesotherapy with dutasteride for the last 7 or 8 years, thousands and thousands of patients, and we have only observed in our patients 3 cases of this paradoxical alopecia, and they were at the beginning when we didn't inject the way that we are injecting nowadays. So I think that the issue is to inject a low we have to inject a low amount of dutasteride per point of injection.
Perfect. And are we done with the questions, Jerry, or is there one more?
There's one more.
One. Okay. Last question, because I know Dr. Vaño's given us an hour of his time, and I really appreciate it. So last question.
Okay, what is the solvent used in dutasteride mesotherapy? Do you use dimethyl sulfoxide?
Oh, is that what he just answered?
I believe so, yeah.
Oh, okay. So there's no other question besides that one. Is there any other?
That's it.
That's it. Okay.
Yes,
Well,
if you allow me to make a final comment, Melvin, I
yes,
think
absolutely.
that the treatment of androgenetic alopecia is not difficult, but we have to individualize the treatment for every single patient, because the success of the treatment is very dependent of the compliance of the treatment. So we are not going to be successful if we prescribe a very complicated treatment for a patient, because the patient is going to stop it. So we have to adapt the strategy of the treatment for every single patient. I think this is the clue.
Consistency, right? You need to be compliant and consistent, just like with anything. If you're not gonna use a medication, if you're gonna be like using it off and on, you're not gonna get the same results. Just before we go, Dr. Vaño, if you could let the audience know where they can find you. Give us your email or social media, or plug any website that you would like to share.
Yes, well, I have different social networks accounts in Instagram, Sergio Vaño G, and in Twitter, and I have a website called sergiovano.com. So we will keep in touch. It has been a pleasure for me to participate in this high-level podcast with you, Melvin.
Thank you so much. I want to invite you personally to the Hair Restoration Network. I know you probably don't have time, but I would really appreciate it if you would register and just interact. Having a doctor of your caliber on the community answering questions would be a huge benefit to us, and I think everybody would appreciate it. So if you have the time, I'd like to formally invite you. But thank you so much, Dr. Vaño. We'll keep in touch. Maybe we can do another podcast soon, or when there's a new development. And if I go to Spain soon, we'll be sure to meet up with you, Dr. Pinto, Dr. Munoz,
Yes,
Dr.
sir.
Ferreira, and everybody else.
We are looking forward to it. Sure.
All right. Thank you so much. Till
Thank
next time.
you. Thank you. Bye
All right.
bye.